Is Gabe. I'm a medical student on the SIR Medical Student Council Biodesign's Innovations Committee. I'm joined tonight by my fellow student, Matt Stankard. Matt, how are you?
Hi, Gabe. Nice to talk with you.
And we're lucky enough to be joined tonight by Dr. Lawrence No. So Dr. No got his MD from Duke University as well as his PhD in neurobiology. He stayed on at Duke for a residency in diagnostic radiology. And after taking an interest in AI and machine learning during his training, he founded a company called Coread AI, where he's the current CEO and also practicing clinical teleradiology at VRAD. On top of all this, he also holds an appointment as an associate adjunct at the Duke University School of Medicine. So just an all-around incredibly impressive guy. We're very lucky to be talking with him tonight. Dr. No, thanks so much for joining us tonight.
Thanks for having me, and I'm honored to be part of your inaugural episode here.
Yeah, definitely. I think we got a good one to start with. So kind of general format for all of you listeners tonight. This is kind of going to be more of a fireside chat sort of a deal. We're going to let Dr. No take the floor in a second. He's going to talk about his kind of career, his journey, founding Coread, and whatever else he thinks is, you know, stuff that he'd like to talk about. And then Matt and I will start with a little bit of kind of Q&A, and feel free after that, we'll open the floor to questions. So feel free to just use the chat panel and write your questions, and we'll make sure that we get to them in the end. We're going to try to be conscious of everyone's time. We know people are busy, people are interviewing, or people have rotations and studying. So we're going to try to keep it under an hour, but we'll just see how things go. So Dr. No, why don't you take the floor and tell us all a little bit about yourself?
Oh, sure. So I'll kind of go through my story a little bit, but I'll try to kind of focus on it through a lens of like the kind of the most common questions I often get and from people who are radiologists or people who are just in general interested in AI and radiology. So kind of the most common question I often get is just like, how do you get started in AI? Like there's a lot of hype about it. A lot of people are talking about it. I imagine most people listening are from a medical background and may not have an engineering background or other technical, background. So like, how do you even get started in learning about AI and seeing, what contributions you can kind of make to the field? So the way that I kind of made my first foray into AI was during my graduate school years. So I was fortunate enough to have some kind of protected research time during medical school. And I was able to, the most contributory thing I think during that period was just learning how to code, like basically how to, program. And that's made it very, kind of made it easier for me to be able to understand the kinds of algorithms that we now work with and just understand just the literature in general too as to what other people are working on. Now, that's kind of how I got my start in AI, but I don't think necessarily, I think coding certainly helps a lot. And I know a lot of people are trying to pursue that path. And there's a lot of good resources now, but there's certainly a lot of collaborators I work on a lot of what I think are really exciting AI projects who don't have that technical background, but certainly can contribute their clinical knowledge to these types of projects. So I kind of got my start there in graduate school and got some, technical skills during that period. And then came like the next big challenge that I think everyone faces, which is once you have some kind of knowledge about the field, you want to contribute, like how do you even just get started on a real project? Like how do you get the data and get things rolling? And when I started a couple of years ago, I think that was a much more difficult task to get good data sets and to be able to work with those data sets. Fortunately, I was connected through another alum at Duke who had contacts at VRAD, Virtual Radiologic, which is a large teleradiology company, and they were pretty forward-thinking and advanced, certainly in terms of from a couple of years ago. They basically had started a AI incubator where they were interested in developing AI algorithms using their large data sets from teleradiology to help with their clinical practice. And so I was connected up with them and basically joined this incubator program where they partner with external partners and basically just open up their data sets and let people, different teams take a crack at, building the best algorithms possible. So I think that was probably the best. I was very fortunate to be able to get connected at that point. And that was probably one of the few opportunities that were available at that time. But certainly now, in general, the field has become much more robust. There are many more open data sets that are being released by whether it's RSNA or other societies. And there are, very robust competitions that are happening online through Kaggle and other, platforms as well. In addition to that, I think a lot of universities and other even private practices are much more advanced in organizing their data and being able to prepare their data for these types of projects. So, I kind of got lucky a couple of years ago to get connected with VRAD. I think the overall environment is just much more wide open now than it was a couple of years ago. And I think there's just opportunities for, a lot of people, regardless of, where they are, whether it's at a big academic center in private practice, as a med student, and, anywhere across the country. And so once we got access to this data, it really got down to then how do we, build these algorithms. And so I think this is where it's very important that, I mentioned the coding skills, which is very, it can be very helpful, but I do want to emphasize that having the clinical knowledge and certainly in this context, the radiology knowledge really helps in developing algorithms in a kind of a more effective way. I know, a lot of these open competitions that people hold, like, for example, the most recent, the RSNA Pulmonary Embolism Challenge, like a lot of the top performers are also radiologists, or at least have some acquaintance with the medical field. So I think basically having some clinical knowledge to guide how you design these algorithms is useful. And I think one rule of thumb that I've used, that is not a universal rule, but is that, if you approach the algorithm design through the way that a radiologist would make the same diagnosis, then that's usually a good starting point. So, for example, if you're trying to build an algorithm based to detect pulmonary embolism, you start asking questions that are relevant to radiologists. So, for example, like, how many slices does it require for a radiologist to scroll up and down to determine whether something's really a PE or if it's something else? And so there's a bunch of different questions that are of that class that really help to design these algorithms. And then, once we built the algorithm, we were fortunate to, run very robust validation on VRAD's data set. And at the end of the day, we were able to perform the best out of all the groups that submitted algorithms for PE. And so then came like the next big question, which is how do we actually use these algorithms? Like, there's a ton of research just building AI algorithms, but it's a whole different beast to figure out how to use these algorithms effectively without potentially getting in the way of radiologists. And so from that regard, we've been very careful in trying to basically stay out of the way. We don't want to build a tool that ends up popping up more boxes or creating more work for radiologists. We want to, stay in the background as much as possible, but still, affect the way that these practices run. And so, between VRAD and us, we thought that triage was kind of a first good use case. And so basically, we have this pulmonary embolism algorithm that's running on all these CT scans that come through, all the CTPAs that come through, and VRAD's a pretty large practice, so the queue can be quite large, especially for non-emergent studies too. And so basically the algorithm runs on all these cases as they're scanned and get loaded into the system, and then our algorithm helps to guide whether different studies need to be prioritized on the work list so that a radiologist can get to that study faster and turn it around, especially if our algorithm believes that there's a high chance that there is a positive, if it's a positive study. So we thought this was a good first step because it stays out of the way. It's basically transparent to the radiologists. They actually don't even get any alerts or anything. It just goes up to the top of their queue, and they're not even aware of exactly why that is, but it certainly decreases turnaround time. And the other benefit of triage, we thought, was, you know, AI is still early on in general, and you know, there's still a lot of gains that we can make in terms of accuracy and things. And so we certainly don't want to lead to patient harm, especially during this early period. As far as triage is concerned, you know, if our algorithm ends up making some kind of mistake, then basically that reverts the system back to the standard of care before such a triage practice. So we felt pretty good about not causing any potential harms, but also potentially providing some benefit. And then I'll kind of end, because I definitely want to get to Q&A and things, with you know, what we're trying to do moving forward here. So I mentioned triage as like the kind of the first clinical use case. Well, our algorithms kind of developed over time to be more accurate, and we're pretty interested in using our algorithms for QA. So what this means is basically you can run our algorithms retrospectively on cases that have already been read by radiologists. And by having an algorithm that looks at both the images and looking at the report, we can find cases that can be flagged for potential misses. And so we've been doing that for pulmonary embolism, for example, and we've been able to find across different institutions cases where there's, you know, cases are positive for PE, but the interpreting radiologists miss them. And so that information can be useful for a variety of reasons, and we can get into that later if there are more questions about that. And then I guess I'll mention one last thing, and I can mention more during the Q&A too, but the last question I get, or at least the last common question I get is, well, once you develop a good algorithm and have a clinical use case for it, how do you actually get it into clinical practice, and how do you get it, you know, into the workflow? And so there's certainly like tremendous technical barriers, I think, that are relevant here. We're lucky with VRAD since they have a very developed clinical system and IT system that a lot of that was done on, a lot of the infrastructure was already done on their end. So it was a very easy lift on our part. But just moving forward, I think there are a lot of very interesting companies that are going to be helping with this kind of task of integration into different clinical practices. One company that we've been partnering with is called Ferrum Health, which helps to integrate a lot of these algorithms in the context of QA into different hospital systems and radiology practices. They kind of handle a lot of the compute services and user interface and things like that to try to make the QA process more smooth. They're one of, you know, several that are doing this kind of platform kind of thing. And so I think that, you know, moving forward, I think the overall theme is that, you know, data is becoming more available. There's certainly more resources out there that are available to help you get started with AI. There are more and more companies that are helping to, make integration and other difficult factors much easier for people. And so, yeah, in general, I'm very excited about where the field is headed, and I think there's just a ton of opportunity for everyone who's involved.
Awesome. Well, thanks so much for that introduction, Dr. No. As a quick aside for all of you listeners out there, I know some of you also logged on after the introduction. And I think with this platform that we're also getting used to, given this is our first webinar, the best organizational kind of way to get around this is you guys feel free to write questions into the chat function. You can send it to organizers only or to everyone, and we'll kind of go through them as you guys send them. So instead of having a dedicated time for it, we'll just kind of integrate them into our Q&As. So feel free to type those, whenever you feel like something comes into your mind that you're curious to ask Dr. No about. So yeah, I think it's so awesome that you're really leading this you're on the forefront of the integration of AI, and the stuff that your company is doing is very cool. You talked a lot about kind of the applications that the avenues you're pursuing with regards to triage. And Matt and I were talking before this, talking about radiology in general. It kind of always comes up when people are talking about medicine and AI. But recently, at least I've heard discussion about other specialties as well. Specifically, I've heard something about dermatology, but also pathology. Given there's kind of the importance of radiologic and pathologic correlation in clinical practice, do you see any kind of interdisciplinary opportunities moving down the road, or any researchers that you know already who are working on this type of stuff?
I think that it's probably early in terms of integrating across different specialties, because I think we certainly have our work cut out for us just looking at a single specialty in itself. But with that said, I think we have been talking internally a lot about there's a lot of kinship between pathology and radiology, for example, and so both in terms of their role in diagnosis, their role in using their use of images in trying to form these diagnoses. And so I think there's probably cutting edge research that I might not be aware of, so apologies if anyone feels slighted by me saying this, but I think it's still probably a little early on for the collaboration aspect. But to your point though, I do think that there's the applications of AI are extremely broad. People often target radiology as like the prototypical, example of a specialty where AI is going to really transform the specialty. But I think at a deeper level, it's going to happen across all of medicine, and probably to a faster degree than people often give credit. So, for example, there's a spectrum. People often say, well, radiology is the soonest of being transformed by AI, and then maybe something that's very heavily people skilled, oriented, like psychiatry, psychology would be kind of way further off in the future. But there's a lot of people who argue that psychology might actually be transformed quite soon, because there's such a shortage of providers in that field, and you don't need to create AI that's better than humans in order to be effective. You really just need to create AI that's better than nothing in order to be effective. So I think the effect will be quite broad.
Awesome. Well, yeah, I think that's fair. Definitely there's already enough work that has to be put into integrating it into radiology alone. So kind of interdisciplinary stuff might be further up on the road. To that end, in your mind, what do you think the biggest barrier is to integrating AI into clinical practice? And we'll talk about all these different things, I think, at some point, but there's legal issues, there's just getting adoption, financing.
Yeah, I think there's a couple. So I talked about just the difficulty of technical integration, and I mentioned how we're trying to address that. I do think that universities themselves and radiology practices are also trying to become more sophisticated in terms of their IT infrastructure, especially with consolidation and things like that now too. So I think that that barrier is becoming easier, but certainly as we speak today, still a very significant, very difficult thing to overcome in a lot of places. The other thing that is a big barrier to adoption, I think, is actually generalizability. There's a lot of companies that develop AI algorithms based on data from whether it's one hospital site or potentially like a handful of sites. There's actually a recent study that came out showing that there's a huge amount of bias in terms of the AI literature. It seems like most studies, if you look at the source of data from AI studies and radiology in general, like there's a huge disproportionate representation from like California and New York, for example. And so a big barrier is when you get these algorithms that seem to be performing quite nicely in these studies, and then you go to a state that's underrepresented in these data sets, or potentially even a different country, how robust are these algorithms going to be? And typically they kind of their performance degrades significantly, and so I think that's a huge barrier in terms of widespread adoption, certainly. And then there's also the issue of regulation as well. Certainly the regulatory aspect is designed to try to help protect patient safety, and rightfully so, because certainly these AI systems, if they make mistakes in the right context, then they can certainly lead to patient harm. They can also affect radiologist behavior as well. So if radiologists, after working with these algorithms for a while, end up changing their behavior and potentially getting a little bit more lax about, doing a complete search for their lung nodules or whatever it is, then that certainly can lead to patient harm as well. But beyond just protecting against patient safety, there's certainly more, I guess, basic difficulties in terms of regulating AI algorithms. I think FDA is still trying to figure out how to, deal with algorithms that change over time, for example. So the classic FDA clearance pathway doesn't quite accommodate for that. And that's something we're sort of, trying to deal with too, because with our algorithms in practice, we're basically have a system in place where our algorithms can get better over time continuously because of the feedback that it gets from its mistakes that it makes every month. So as we feed that back and improve our algorithm, that makes the algorithm a moving target for regulation. So that's another difficulty there. And then in terms of just, I think you mentioned like the funding environment and things like that. I know that, these funding can kind of go in cycles, and there can be, there's an initial very intense interest in AI, and then there was a little bit of a falling off. And people are speculating that maybe there's going to be another rise now, given that at least it seems that in recent news, the Medicare and CMS seem at least willing to potentially reimburse for the running of AI algorithms on radiology studies, at least to some degree. And so maybe that might lead to another, rise in interest in investment and things like that. But yeah, I think those are kind of the major barriers there.
And I think you have touched on this once or twice now, but one of the things that I find really interesting is, one of the issues with artificial intelligence as it relates to radiology being the availability and access to of these high quality data sets, like you mentioned that you had access to at VRAD, and certain generalization issues as well. In your experience, what is the path forward from those types of situations? data sharing has been an issue in clinical medicine, especially with training algorithms. How is this circumvented?
Well, I think a lot of people have done really good work in terms of trying to open source a lot of these data sets. So for example, I mentioned this earlier too, like the RSNA PE competition that just ended recently. It was collaboration across many different sites, basically making this data, well, very carefully de-identified data available to the general public. So people aren't even, anywhere around the world. If they just sign up with an account on this website, then they can download, a ton of data, thousands of, CT scans. And so projects like that, I think they're difficult to get off the ground. There's, a lot of work that goes into it, but it certainly benefits the community an incredible amount. I think just the number of data sets that are becoming available like that are just growing tremendously over time. And so I think that helps some. I know that the other thing some people are interested in is this concept of federated learning, which is a way to potentially train it, well, not potentially, people are doing it, train an algorithm without sharing data. So for example, let's say you have site A and site B and site C. They all have private patient data, but they want to together build a, let's say, a liver segmentation algorithm. There's a way for each of those sites to just hang on to their data, keep the data, secure in their sites, and potentially pass around some of the data that's associated with the algorithm itself, some of the weights and other parameters, and they can kind of train one algorithm across data at 3 different sites without ever moving that data from site to site. So there's some interest in using that kind of approach as well to get around some of the data privacy and ownership issues. And so, and then, the approach that we've taken, and I think will be increasingly salient too, are these large kind of mega practices that have a footprint across hundreds of hospitals. For better or worse, radiology, like these large practices, are kind of buying up more and more small practices. At least from an AI perspective, it does give these large entities quite an advantage in terms of having a very generalizable data set that whether they or partners that use their data could have access to.
Great. Yeah. I think that is interesting in the fact that how consolidation is really going to play a role in both the procurement of data, but also, what kind of people are working with these data sets and how that shapes AI in radiology. The next question kind of comes from the, entrepreneurial side of things. So, I know myself and probably quite a few other listeners have some entrepreneurial aspirations and interest in innovation. And, as a, physician scientist and now a physician innovator and scientist innovator, are you full-time working with your startup right now, or are you still working clinically with VRAD? And if so, how do you balance the obligations to co-read with clinical practice?
Yeah, it's a good question. So I have to say things were much more difficult during residency. So as you may know, residency demands a lot of time of your day, and it's impossible to fully feel like you're running a company well and learning all the things you need to learn in residency and do all the clinical duties associated with residency at the same time. So right now, I finished residency, and so I am working full-time on the startup, but I do basically like a little bit of part-time teleradiology to keep my clinical skills up. And I do think this is super important, which is I do think that there's a tendency for people to drift if they don't do real clinical practice on a regular basis, and drift not in terms of just clinical skills and impact on patient care, but also drift in terms of their insights into things like we're doing, like the entrepreneurial stuff. Like I think there's this tendency to start working on kind of problems that are not as important if you're further removed from the trenches than it is if you basically read a handful of studies in the morning and then you turn around and do some of the entrepreneurship stuff. And so I guess to answer your question, like I kind of have a foot in both right now, both running the company and the clinical practice, and to the degree that that's available to people in the field in general, I guess I highly endorse it, because it certainly helps with the entrepreneurial pursuit. And certainly, like I also have the added advantage of just being part of the same practice that uses our algorithms, so I'm able to see some of the nitty gritty and some of the issues that come up, and to help with the business.
Yeah, I can definitely see how you maintaining your clinical skills and acumen, just the crossover of skills seems so necessary when doing this type of work. I would like to ask though, while we're on this entrepreneurial topic, what sort of financial incentives and drivers are like currently in place in the field of AI as it is today? And I kind of wonder, are there any incentives that would specifically favor a larger company versus a smaller one? Or if there's anything, or if anything that would favor a larger versus smaller company, or any sorts of differences in that paradigm that you see?
So you mean in terms of like size of like the AI company, or are you saying like small versus large AI company?
Yeah, are there certain advantages that a larger company has versus a smaller one? And also just what is the monetization strategy of these companies?
Yeah, that's a good question. So for small versus large, in my experience, it seems like the startups are doing much more innovative and are making more progress in radiology AI than some of the larger companies may. I might not just be aware of everything that's going on, but I do think that there's some degree of having to move fast and kind of just the classic entrepreneurial startup speed that needs to happen. So going back to the incubator or other things, like I think that in general there are cases where like small companies have been able to build algorithms that are either as good or surpass those of very established tech giants, for example. That's not always the case, but obviously, like for example, Google and DeepMind have far surpassed any other startups of capacity to play games like Go or chess or something like that. But it seems like, at least in the radiology AI space, size it almost seems to favor small companies. And of course, I might be biased in that assessment in general. When it comes to reimbursement strategy, that's a huge problem / question for the field in general. As I mentioned before, like the recent development that has made that issue a little bit easier, or at least there's a more concrete pathway that may exist, is that CMS / Medicare, that they basically allowed for a CPT code to be assigned to an AI algorithm to run on certain types of studies, and in that case it was for a CTA looking for a large vessel occlusion. And so several companies have access now to being able to allow their customers to bill that CPT code for the use of, you know, their algorithm. So that certainly opens up one avenue for revenue. But I think other companies have tried to be a little bit more creative in terms of revenue here, because you know, with for example, our approach to QA, on the face of it, you're like, well, you're helping radiologists catch some errors, and that from a financial perspective, you know, that reduces potentially maybe their malpractice liability or something along those lines, which is good. I'm not, that certainly is not something to balk at, and certainly it can potentially lead to better patient outcomes as well, which is good too. But yeah, how exactly does that connect to you know, a revenue, you know, a strong revenue stream? And so with the partners we've been working with, the name of the game hasn't really been in terms of per se like reducing medical malpractice liability, but potentially reducing costs for the health system in general. So for example, the idea would be if, you know, we help reduce the number of radiologist errors for a certain condition, over time that should lead to a significant decrease in costs for the health system in the care of that patient. So whether it's for that admission or for, in general, for like, let's say an insurance company covering one of its members, it turns out that the it's kind of like the downstream effects of medical errors can be, you know, an order of magnitude greater than the impact that it has on the radiologist. So I guess, you know, it's still early on where people are still trying to explore these kind of financial models, but I think the general idea, at least as it impacts radiologists, is, you know, the larger health system has interest in potentially implementing these AI systems because of you know, larger system-wide healthcare cost savings, and so therefore AI may not necessarily always be a kind of system that, you know, radiologists would have to pay for example. Like I think that's a question I get a lot, which is, you know, radiologists have and practices have a certain, you know, revenue model. Like how much can an AI company really, you know, eat into that, you know, profit margin for whether it's a private radiology group or, you know, a hospital or whatever it is. So, yeah, in general, it's still early on. We're trying to explore a lot of different, you know, business models, but I think that seems to be the promising one, at least in our experience. And I know other companies are exploring a, you know, wide variety of other things.
Yeah, I think it's important to talk about kind of the topical nature of, you know, there's the buzzword of value-based care running around medicine these days, and it's a little nebulous, but definitely people are trying to contain costs throughout the healthcare system, and finding ways to get AI involved there, I think, is kind of a natural path towards things. So that's really interesting. I just dropped a line to everyone. You know, we got a couple, maybe two more questions for Dr. No from our end. If anyone else has other questions they want to get in, just feel free to drop them in the line there. I think the next thing I'd love to know is, you know, for people like myself who are interested maybe in following in the footsteps of, you know, innovation like you've done, how did you know, when did you get bit by the startup bug, and how did you know when it was the right time, you know, to actually go out and form a company, to raise funding? You know, you're an MD, PhD, and you did your residency, and, you know, there was just wondering how you came, when you decided it was time, you know, to get going.
I think when I decided to do it, again, it was a couple of years ago, not too long ago, but it does seem like a little bit of a different kind of era for AI. I guess in my experience, at that time, it seemed that the private sector was a little bit more advanced in terms of giving people access to data and having all this data well curated and ready to go for development. And so when you're dealing with kind of whether it's a private practice like VRAD or other practices like that, I guess I felt like the best infrastructure to use was a startup, which is, through a startup, I can, develop intellectual property, contracts with these companies and, have, basically negotiate things on my own term, like between the two of us. The alternative was, whether to go through academia entirely. At that time, again, this was just the happenstance at that time. It was just a little harder to get data out of academia, I thought, and also it was just a little new in terms of AI and radiology, and I felt like I had to move a little faster. I think things have changed now to some degree. Again, certainly academics are very involved in AI. There's a lot of startup companies and spin-off companies that come out of universities now. And so I think that landscape's a little bit more robust. But in terms of when to actually form a company and et cetera, I think it's basically, when you have some idea that you'll be able to develop some intellectual property that you want to, own/protect under an entity. And if you're in the business of trying to get out there and, have a business plan and things like that, and, raise money, raise profit and get profit and things like that, then certainly that would be a good time to pull the trigger. In general, starting a startup is, just like I said, before with our partners and solving technical issues in terms of integration, like the whole ecosystem for startups is pretty robust too. So the actual, process of getting a company up and running is, relatively streamlined, especially if you partner with the right, legal firms and things like that. So again, this is just my path through, which was to form the startup and kind of go it alone in terms of forging forward with the development and negotiations and contracts and things. But I think there's also a very compelling argument to be made of potentially doing a lot of the same things now under the umbrella of academia as well. And so, especially if you're at a university that has a lot of resources in terms of supporting entrepreneurship and supporting innovation.
Thank you so much for that, Dr. No. I think this is going to pretty much wrap up our time here for the evening. I wanted to give you our sincerest thank you for coming on and sharing your perspective and knowledge with both trainees and physicians and residents alike. From the bottom of my heart, we really appreciate you taking your time here tonight.
Yeah, I appreciate your organizing this.
Of course. Okay, so what I'm going to do from here is I'm going to leave my email and Gabe's email in the chat box for anyone who has any questions or would like to follow up with us for any reason. But otherwise, I think I will end it here. Again, thank you, Dr. No, so much for your time.
Absolutely. Take care.
Thanks, everyone, for coming out tonight.
Yes, thank you, everyone. I'm not sure if I've mentioned this before, but this is going to be the first of a 4-part series to be held monthly in conjunction with SIR. So please look out on social media for different marketing emails. You can register for those as well. All right, thank you, everybody.